Well, hello and welcome to the top 5 injuries that are dominating 2023. And today we are going to open up the vault and we're going to reveal some of the case trends and some of the insights across your entire employee population. So if you've ever wondered, how do I stack up against some of the others? What do my numbers look like against other people? How can I better manage some of these injuries before they go off the rails? Then you have made it to the right place. My name is Holly Foxworth. I'm one of the registered nurses and the marketing manager for content here at Axiom, and I'm joined by 2 familiar faces that you see frequently here on the webinar, which is Dara Wheeler and Dr. Scott Cherry. You'll meet them momentarily, but before we get into that, let's go ahead and get you acclimated to what you're looking at there on your screen and where you need to pay the most attention to. So if you look on the right-hand side of your screen, that's where you should see a blue box that says RSVP. That's the button that you're looking for. That is going to get you registered for our next event in December. It's our final webinar of the year. And so that one is called 2024 Workplace Trends and Predictions that you need to know. So we'll go through everything from labor market forecast to OSHA changes, projections about physical and mental health, well-being, some of those changes that are going to take place in the workplace there. And then also just kind of give you an overall blueprint of what you need to know, what needs to be on your radar for this next year. So you don't want to miss that. If you'll just press that blue button, that'll get you registered. You don't have to enter any information. Just press the button. That'll get you registered and we'll get you moved over for that one. Now, towards the bottom of your screen, you should see a box at the bottom, and it's going to be what we call our Q&A box. So if you like gifts, that is the place that you want to be seen and heard. If you have any questions throughout the event, whether they be comments, whether it be something that's specific to your workplace, whether it's something that we're discussing here, put that in that box and send it to us. We definitely want to hear what's going on your side, and so that we can better tailor some of our events to meet what your specific needs are. So this is definitely a safe place where you can bring up anything that you want to talk about, and we're happy to go through that with you. So at this point, let's go ahead and meet our panel. We'll start with Dr. Cherry. You want to go first, and then we'll follow that with Dara Wheeler.
Certainly. Thank you, Holly, and good afternoon, everyone. My name is Scott Cherry. I'm Axiom Medical's Chief Medical Officer. My professional background is I'm board certified in preventive medicine, public health, and occupational environmental medicine. And I've been supporting the military, government, and industrial operations for the past 15 years. And it's a pleasure to be with you.
Oh, thank you so much. And Dara?
Hi, Holly. Hi, Dr. Cherry. Hi, everybody. My name is Dara Wheeler. I'm Axiom's Chief Marketing Officer. This is my 17th year at Axiom, is what my resume says. And I have been really excited to talk to all of you over the years, and we'll continue to have these conversations about injuries and how we can support your employees in the workplace.
Fantastic. Well, before we get started and kind of go through what our discussion topics are going to be, I'm going to go ahead and put up a poll question here on your screen. So what do you think, what day of the week do you think has the most injuries? Would you say that would be Monday? Would you say it'd be Wednesday, Thursday, or Saturday? Let us know what your thoughts are there while we go through the discussion topics. So what we will be discussing today will be the injury landscape of 2023. We're going to go through some of the case trends, give you some insights there, and then we're going to take you through the top 5 injury types. So we're going to start at number 5 and then work our way up to number 1, which is the most common, and then we'll give you some additional insights and best practices there. Dara, I'll come to you first. Let's see. Oh, are you surprised? Dr. Cherry or Dara, are you surprised by the results here? Most say Mondays.
I'm not surprised at all.
I'm not surprised either, because you do hear stories of those injuries that come in on Monday mornings. Yeah, but let's see. We'll go on to the next one and actually let you talk us through it, Darren, and give us what the real story is.
Yeah, so some real stories here. And this is Axiom's data. I want to just preface that. So we know that our industries that we work with are very specific to industries that tend to get, or where employees tend to get injured more frequently and have very specific types of injuries. But these are key takeaways that I think we can make more broadly with a lot of industries. But So far, year to date in 2023, what we're seeing from our data is that most of our injuries are reported on a Thursday, which is very interesting. And the time frame for those injury reporting is not in the morning either. So you might think first thing in the morning, and somebody's showing up for work, and this is, Monday morning, they're showing up, they are reporting their injury. And we typically see injuries occurring and being reported to us between 12 to 6. And there's a lot of different components to this. It depends on shift work and when shifts start and end. We have a lot of clients that have shifts ending on Wednesdays and starting on Thursdays. So when we look at data coming back to our clients, we look at all these different trends and where we could potentially help impact injuries and help prevent them. This is data that we share back with our clients. We do look at benchmarking data for other individuals out there or companies out there. But Axiom trends, we're looking at about almost a little over 74% are staying in the self-treatment realm. And then beyond first aid. And we'll go to Dr. Cherry in a little bit and talk a little bit about the difference between first aid and treatment beyond first aid and what that looks like. Holly, was this surprising to you when you looked at it?
It was, yeah. Whenever I pulled this information, I was almost kind of thinking that Monday would be a day too, because whenever you're speaking with some of our clients, that usually is a pain point. There is that everybody comes in on Monday morning and it's like everybody had a weekend injury or something that had occurred on Friday, and so they're reporting that. So it got my attention for sure. It looks like
and
for me,
yeah,
go ahead,
audience agreed.
Dr. Cherry.
Yeah, I would say I was very surprised, and I'm more like the audience where I would have, chimed in on Monday, because there's a number of factors. So if it's physically demanding work, if you're kind of coming off the weekend, you may not be kind of warmed up for that physically demanding work. And then also, I think there's a tendency to think there may be some higher injuries on Friday because people are kind of thinking about the weekend, maybe forgetting their safe practices, maybe in a hurry. But, this is pretty compelling data. This is a robust data set of over 14,000 injuries over the past 3 quarters. And so this is not a small data set for the statisticians there. And actually, you probably could argue that there's not a significant difference between Monday through Friday. So again, that can help inform folks thinking about how to, educate employees about our Mondays and Fridays actually, higher risk, so pretty interesting.
And I was going to mention, I think our data has shifted over time. And I do think we, in early days of Axiom, saw a lot more clients working 24/7 shifts. And so they were working overnight shifts, working weekend shifts. I think that has shifted a little bit in the populations that we're managing. And so when you think about retail and some other shift work, this is starting to change our landscape a little bit in how we manage injuries. And I think one of the most exciting components of data that we're starting to dig into is looking at injuries and how to help clients prevent them with information points like fatigue. And Dr. Cherry, we can talk a little bit more later on about fatigue and what that means in the injury realm. But I think this information is very much an area that clients, when they see it, really jump into and start thinking about their shifts and how employees come on and off shifts and when.
Yeah, definitely. Tell us what your thoughts are about that. Are you surprised by this data? You can put it there in the chat box. It looks like that we got one that said, let's see, so far Robert was saying, from a behavioral safety aspect, what do you think that is? Any thoughts there, Dr. Cherry, on what that could be? Do you think that there is an association between the day of the week and when these injuries are occurring?
Dara, I really appreciate her, long-term experience here at Axiom, because she kind of gave us a tidbit there that, the clients that we serve are potentially changing how they're managing their shifts. So if we have a huge bulk of shift change in the middle of the week, that could kind of be a confounder in the data to where maybe if there wasn't that shift change midweek, perhaps there would be even more injuries on Mondays and Fridays. But with that shift change midweek, that's also potentially the Monday and Friday of kind of the traditional banking hour routine. And so I think we would have to parse the data further from shift work to kind of a regular working week, just to see if that's the case. Because again, there is a lot of intuition that Monday and Fridays may be, or better, maybe better said, is the beginning and ending of a shift week or shift period may be the higher risk. And so, I think I would have to look at the data in kind of separate ways to kind of, tease that out.
Yeah, definitely. Carol had also mentioned in there that worker fatigue could be a contributor, and that makes a lot of sense, especially when it's later in the week. Well, let's get into some of the injuries. And like I said, we're going to start at the bottom, and then we're going to work our way up to the top to the most prevalent. But heat injuries jumped out as number 5 for this time period. Dr. Cherry, this is a new one, correct?
Mm-hmm. And I love looking at this kind of population health viewpoint, because if you talk to our nurses and even a lot of our operational folks, summertime gets really busy with heat injuries, obviously. But in some ways, I would have almost guessed, if you were to poll me, Holly, that heat injuries would have been higher than 3% of our cases. So again, we're looking at over 14,000 cases for these last 3 quarters, and just under 500 are heat injuries. And, the old school term for this was, heat exhaustion and heat stroke, kind of for mild and severe. But this has really been an ongoing issue for OSHA. In fact, they've recently intensified their enforcement of it and really are starting to focus on high-risk industries like agriculture and construction. And I've learned a lot about when I rotated through OSHA, where they really look to make new rules through a proposed method, which ends up becoming federal law. So there's really rulemaking that's being potentially promoted right now for a national emphasis program. And really, I think what happens is you have two types of risk of employees for heat injuries. You have those that are brand new to the job, and so they're not acclimated to the heat or to the work, especially if they start in the summer. And you also have kind of the long-term employee that either complacency hits them, or they might start on new medications or develop a new type of medical condition that makes you much more susceptible to heat injuries. And so definitely want to think comprehensively about heat injuries, especially if you're noticing more and more injuries in your patient population. And so, employer responsibilities include, providing really sufficient cool water, rest breaks, and then rest areas. There's some good guidance out there from the industrial hygiene profession about work rest cycles based on temperature, and it's called a wet bulb globe temperature. And so a good, HR or policy for this is really to allow for periods of heat acclimation for new or returning to work employees who've been out a significant amount of time, because heat acclimation is actually I don't want to say it's a cognitive skill, but it's a physiologic skill that our bodies may take up to a couple of weeks or longer, depending on the person and on how extreme the heat is. And you really want to help foster focus on prevention and signs and symptoms of heat illness, and how to immediately kind of address it. And one thing that I've always I thought is very interesting is sometimes the heat injury actually manifests on the cooler day of the week. So say you're starting out and it's hot all week, and then Friday, end of the week, it's actually cooler, but there's this cumulative aspect of heat stress to where it may actually manifest on a cooler day. So a lot of times people or employees feel like, oh, this can't be heat because today is cooler than it was yesterday. So kind of a sneaky aspect of this type of injury.
Absolutely. And Dara, we've seen that the outcomes from some of these have been all over the place, right? I mean, you have some that can be managed appropriately and some that go off the rails.
I love what Dr. Cherry just said. I just want to sit on that for a
Mhm.
second. I don't think I've ever heard you articulate that in that way, where it's not the heat of that day that may be
Mhm.
causing the
Yes.
issues. It is the lead up to that day and what our bodies have been doing. And I know we've talked a lot about hydration beforehand and medications beforehand and all these things that could contribute to somebody having a heat related
Mhm.
illness during that specific day. But I hadn't really thought about the fact that
Mhm.
it might not be because today is 100. It might be 85 outside, but the accumulation of
Right.
things over time, I thought that was really, really interesting. Um,
Yeah.
Yeah.
and as both Holly and Dr. Cherry have mentioned, I mean, this is not new. We've been
Mhm.
talking about heat since I've been at Axiom, and I know since Holly's been here. So it's been over a decade that we've been talking about it and providing guidance and support for our clients. We had one client, and they had two cases happen in the same day. And this was a really interesting example for us because you had one employee have some symptoms that were related to heat go straight to the ER, and one called us. And I know this is a bit self-serving to show how great we are, but I think it was a really interesting example for this one client to say either way, the outcome was heat. It was a heat-related illness. One, the cost associated with it was astronomically high, and because of the way that they treated it in the emergency room, the employee was off work, ended up being recordable. And by thinking about things from an early access to care point of view, if you get an employee supported immediately and starting on to recover with some first aid recommendations, it's not that we're always going to prevent somebody from having to go in, but at least you get them going on the right path, and that process really does make a difference in the outcomes. So it's something that we pay a lot of attention to as we ramp up to summer. We, on the flip side, often we're about to hit winter. We see a lot of slips and trips, and we'll talk a little bit more about ice and what that looks like in the winter with a lot of our clients. But as we near summer, we really try to get out there and start talking about this with clients because we are we still, I mean, number 5, we're still continuing to see a lot of those come through. And if you get a supporting process like Axiom involved, it doesn't have to be Axiom, but if you get somebody involved that can help mitigate that that outcome and manage the process, then you end up not necessarily spending the 40K on an emergency room bill.
Yeah, absolutely.
One thing to just reinforce here is, these are two extreme cases, or the outcomes are extremely different. And what I would say is, it's absolutely plausible if, someone goes to the emergency room with complaints of dizziness, fatigue, especially if, say, for instance, the employee is over 40. Heart disease is the main cause of death in America, with probably 1 million deaths a year. And so emergency room physicians are absolutely geared to think about heart attacks as the biggest risk, right? And so someone under 40, the risk of heart disease is, lower, but again, the ER physicians are going to be really looking to rule out things that are going to potentially kill their patient. And then if it's something minor, then they kind of rule out all the nasty things and kind of then feel okay to releasing them. But, someone over 40 with, just weakness, they're going to be thinking about their heart. And so the cardiac workup can be quite costly. But again, that's the whole reason the ER is there, to prevent, emergencies. And so, again, this is probably much more plausible than I think the average non-medical person realizes.
Mhm.
Great point, Dr.
Absolutely.
Cherry. And not to derail us, but your point about heart disease as an underlying condition, I know one of the areas that we're really digging into is comorbidities. And one area that we may be seeing as a bit of a headwind for the safety industry is that employees at a younger age are coming in with not just one, but multiple comorbidities at a rate they might not have in prior decades. And so they might have heart disease or other concerns at a younger age than they would have 20, 30 years ago. And so for somebody that's having symptoms that could be either heart attack or heat related illness, then you really end up in this place where medical support will be critical, right?
Absolutely.
Yeah, we discussed this at length in our client summit this year, where obviously safety is looking to prevent every injury if at all possible. One thing we started looking into the last couple of years is how comorbidities actually are a risk factor for injuries in the workplace and at home. And so, having that background information about your employee population is critical, because if the prevalence of chronic medical conditions continues to go higher and higher, that really is a headwind for the safety aspect of injury reduction. And so even keeping injuries at a plateaued level may actually be a win for the safety department if they can show that, hey, we're keeping injuries at this level despite our chronic medical conditions going up in our worker population.
Absolutely. Yeah. Tom was asking about would age be a factor, and yes, it definitely could be a factor in some of these injuries that are here. But Mara had asked a question from the State Compensation Insurance Fund, and I love this question. It was, I'm assuming that most of the injuries of heat illness are related to working outside, such as construction and agriculture, but do you see injuries related to indoor heat-related illnesses? That's been a big topic lately.
Yeah, certainly. A lot of indoor functions are not actually air conditioned and might even be hotter than being outside. I've done some worksite visits that were really very impressive from a heat perspective, where you have large warehouses that aren't air conditioned. And so, it really matters to get objective data about what's potentially happening in the indoor setting. So having temperature would really be a very interesting metric to have, versus just saying, oh, these folks are okay because they're indoors.
Sure.
And I think your point about
intensity of.
No, go ahead.
I'll just finish up and say it also depends on intensity of work. And so you can be, if you're doing heavy work, these are defined worker categories based on Department of Labor, but anything above even sedentary work in humid or warm conditions, especially if it's heavy or very heavy work, can be dramatically large heat stress, depending on the personal protective equipment they're having to use as well.
Absolutely. Yeah. Well, Dr. Cherry, I'm going to take you to number 4. Talk to us about head injuries.
This topic gives me a headache. That's my joke for the day. I'll have to get some feedback from Jason, our resident comedy expert, to see how I sold that one. I probably could do a little better next time. But, so again, we're counting down. This is number 4. This is about 550 cases, which is only about 4% of our 14,000. And falls are really the leading cause of head injuries, or, the medical term is traumatic brain injury. I think this term has become much more popular. When I was in the military, TBIs, or traumatic brain injuries, became very, it was a topic that was very popular in the military, but probably even in the general population. And then I think with football also looking at traumatic brain injuries, it's become more popular, and more non-medical folks are kind of thinking about this. But, really risk of falls from ladders, scaffolding, roofing. So it's a fall from elevated height. It can be a fall at ground level, but still hitting your head pretty hard. And then also being struck by falling or flying objects. So obviously you can have a mild traumatic brain injury to severe. Um, and so when you kind of get your bell rung, as they say, you kind of have these generalized kind of symptoms. Some of them almost make you feel like you're ill than injured, but you may have a headache, nausea, vomiting, fatigue, difficulty with speech, dizziness, sensitive to light, blurred vision, ringing ears. And then for severe traumatic brain injuries, you have a loss of consciousness, extended disability with persistent strong headaches, vomiting, confusion, seizures, and then even coma. And so, these are, can range from really just mild to really very concerning. And so you really do want to get some professional guidance on this type of injury as soon as possible. Specifically, nausea and vomiting with a head injury is very concerning, with concern of a brain bleed. And so again, you want to really seek consult in the work-related arena. You really do want to have every injury kind of evaluated to a degree to make sure you're moving forward and not missing something that can be severe.
Absolutely. We're going to take you to another poll question before we get to number 3, because this relates to it. So we'll ask you, what type of PPE do you think that employees most frequently wear? Would you say that that would be the safety goggles, some eyewear? Would you say it's boots, maybe gloves, or hard hats? So let us know what you think that your guess would be there, and then we're going to give you the data for that. But Dr. Cherry, I'll let you go ahead and talk about some of these skin injuries and the injuries that are associated with that. Those are the types, but the actual injuries that are associated with those.
Certainly. And so again, this is number 3 of our top 5 with 945 cases. So this is about 6% of the injuries we're seeing. So if you notice, we're really looking at a very small percentage right now of our total injuries. But again, they're very important and relatively common. And, so with skin injuries, we're really thinking about abrasions, lacerations, and burns. Just a reminder that burns can be caused by, a hot surface, or it can be chemicals, electrical, or even radiation. And so, you can actually have a skin injury from something that's not just hot. You can also kind of get it from extremes of a temperature being very, very cold as well. And so again, use of personal protective equipment is very important. I know with all of our injuries, we do assess, personal protective equipment utilization. 1, it's a great metric to feed back to the employer, but 2, it dramatically tells us if there's some type of protective factor that may lead this outcome to being less severe. So again, it's really a great metric to be utilized in many ways.
Mm-hmm. Dr. Cherry, the skin injuries, it feels like that one that they can go off the rails very quickly. And from an outcomes perspective, especially from an OSHA recordability outcome perspective, some of the lacerations, we see that they're getting a lot of prophylactic antibiotics. They're maybe going a more aggressive route. Can you speak through that?
Certainly, there's definitely reasons that a minor injury can immediately be sent as an OSHA recordable. And so OSHA has these rules for what's considered medical treatment or first aid treatment. So anything that's not on that list, if it's beyond that, it's considered medical treatment beyond first aid. As soon as that happens, it's considered an OSHA recordable, and there's really not a lot to be done about it then. And so I agree with when you talk about lacerations, sometimes the provider may always be looking to do sutures. Whereas if it's a minor laceration, there can be alternate ways that are just as effective as sutures, but don't necessarily make it OSHA recordable. On the flip side, Holly, like you said, too, these can be a little bit tricky. So depending on the person's personal medical history, we, based on our years of experience, may actually move this type of injury to a higher concern just to make sure there's the best outcome in case they're at much higher risk for infection and things like that, depending on the personal medical history. So what may be considered a small skin injury to the actual employee, the supervisor, or the safety, we still, again, may, again, based on kind of some other assessments, elevate that to make sure that they don't move into an infection, which can be very difficult for certain chronic medical conditions.
Yeah, agree. We did have a great question that came in from Michael about this one, and he was asking, are the treatments different between hot surface burns and those that would be cold temperature burns? Excellent question.
That's really good. And actually, in general, no. If we're talking about extremes of temperature, sometimes with electrical burns, depending on the severity, those are treated much differently and much more conservatively. So they would be going to the hospital, things like that, because that can manifest later. And then also chemical burns. Again, we're talking about the skin, but we also worry about inhalation, which can be really life-threatening, and so I know our nurses are just really teed up for catching any of those types of things to where it may be not apparent to anyone that there's a concern for airway issues, but later on they can have a significant swelling. And so, that's a great question.
I think the inhalation component is always an interesting one. And I know we have a case study that we've talked about for years at Axiom, which is a really interesting example of why having medical intervention as your first phone call is so critical, because with an inhalation, like you said, you might not think the employee is dealing with anything life-threatening. It might look fine. The employee might look fine. Everything's fine. But really that is a critical case that needs to get, I think the employee that we were dealing with, everybody involved was like, yeah, the employee's fine, no big deal. And the nurse said, no, we're getting this employee life flighted, and saved his life. And sometimes those don't come up on these, we've showed a lot of stats, and that's not a stat line. That's like hey, this guy is alive today because somebody made sure to take care of the inhalation exposure that occurred. So it's always that, having somebody on your side and making sure that to help make those decisions. Most of the time, that's not the scenario. Most of the time, these are relatively minor, can be treated with first aid. But on the other side, having somebody to pull the emergency cord and say, no, this is truly a big deal.
Absolutely. Yeah.
Yeah, exactly. Again, most things are going to kind of be what they look like, but I think for some of these exceptions with inhalation, but the other thing, Dara, that I think is more challenging, and it's probably more common now, is because the employer can't know about chronic medical conditions, they're really blind to that. Or, if the employee actually does disclose that, then you have to kind of treat that very specifically, because just because an employee discloses it to a safety doesn't mean that the safety can keep disclosing it up the chain. So I think it's the chronic medical conditions that are the higher risk from a kind of a foot fault, as our Chief Legal Officer, Chuck Cable, says, into kind of a privacy violation. And then even more rare is these life-threatening events that may not be readily apparent to a non-medical person.
For sure. Well, Darren, now that we've spoken about some of these skin injuries and we've taken a poll, let's look at what the results are here, and then we'll actually pull our data of what your employees have reported here. So number one, it looks like the number one answer was boots. Either of you surprised with that one?
No, I would have probably guessed boots.
That was my choice too. That was my choice too.
These are excellent guesses, but here is the actual data from the information that we collect whenever these injuries occur. Derek, you want to talk us through this one?
Yeah, and this is always self-reported, so it's interesting because this is reported at the time of the injury. So we look at what was worn, like Dr. Cherry said, it does help us determine next steps too, because if somebody was hit in the head but they were wearing a hard hat, there are different levels of response once we know what type of PPE they were worn. So about 85% of our injured employees reported that PPE was required, but at about the same number said that they were also wearing their PPE at the time of the injury. So those two numbers are really interesting. Definitely boots, safety eyewear, and gloves are the top PPE worn. And hopefully a lot of these employees are wearing all three or multiple forms depending upon their job. But it is something that makes a difference in the way we manage injuries because of the way that the mechanism of injury occurs, what they were wearing, all of the different components go into how our nurses look at supporting the injury process.
Absolutely. All right, Dr. Cherry, number 2, multiple injuries. What type would this be? What type of injuries usually fall into this category?
I lost my joke on this one. No, I'm just kidding. I got to get some better material. No, just kidding. I only have one joke per webinar. That's my limit. My agent said to do so. But, so again, this is number 2. So we're getting to, a much larger proportion of the cases. So we're kind of just under 3,000 cases for the last 3 quarters. And so this is, again, a huge increase from number 3. And so this is 19% of all cases. And, mechanism of injury is really the absolute most important thing for any injury. That's really what we focus on here at Axiom Medical. What happened, what severity, just everything about the mechanism of that injury. And so for multiple injuries, what's really the leading cause is motor vehicle accidents. And, I was born before the cell phone, and, I think driving was still very risky, but now I think distracted driving is getting to a level that is probably very scary. And then also, I think with people's chronic medical conditions leading to, say, poor sleep, like sleep apnea, or that's where people can't breathe while they're sleeping. And so they're waking up and they're not aware of that the whole night. They may have hundreds or even 1,000 micro wake ups at the night, or they're on a medication that, may be affecting their sleep, whether it's from a mental health medication or attention focus component, or just substance abuse, are really all risk factors. And so again, this is a very challenging component for employers, but again, this is a huge bulk of the injuries out there. And so you almost need to have like a multi-prong approach. We're seeing, really monitoring technology that is helping employers feel like they have a proactive approach to fatigue risk management. And then I know we've actually are moving forward with actually screening for fatigue and all injuries, which I'm very excited about because it will start giving us a lot of insight into if fatigue is really highly associated with the injuries that we're seeing. And then we can give that information back to our clients to where, this will be data-driven decision-making, which, really can inform each client what really needs to be done along these lines.
Mm-hmm. And when you say fatigue monitoring, like what type of questions? Could you give us an example of maybe just a few that they would be asking to use
Certainly,
for that type of screening?
And really a lot of us here at Axiom with our years of experience kind of worked on this. But I remember when I was internal to a large company, when we were part of the root cause investigation, it always seemed like that person who had a severe injury was either on shift for an extended period of time doing overtime, or they had been working a huge number of hours leading up to that type of injury. So again, we're looking at like fatigue from all aspects. So what time did you wake up that day? How was your how many hours? So quality and quantity of sleep before the shift. How many days have you been working consecutively? How much overtime have you worked in the last week or so? Things like that. What's interesting to me is I've been actually monitoring my sleep for the last few years, and quite shocked at how poor my sleep is. Even when I go to bed at, say, 9 and wake up at 5 a.m., I'm thinking I got 8 hours of sleep, and then my sleep tracker is like 4.5, and so that's really concerning to me, as just caring about myself as an individual. But for those who aren't even able to sleep that much, or if they're doing overtime, so again, quantity and quality of sleep is huge. And then cumulative fatigue from just days at work, as well as overtime.
Mm-hmm. Mm-hmm. I would think that the MVAs would also be high liability there as well, especially for some of the more severe. Yeah. Dara, anything you wanted to add to that?
No, other than just a side anecdote, I heard somebody say that when we think about safety and risk in something like a motor vehicle scenario, years ago when we started having cell phones, they started making laws to change our behavior. And one of the laws in driving or doing, not hands-free. And so, what people started doing? Hiding their phone and texting and driving, which actually led to more incidents, because now instead of somebody doing this and still kind of paying attention to the road, they're now head down texting under the steering wheel, and actually less safe. So it's just thinking about how we change this over time. I know that a lot of our clients are behavior-based safety and looking at behavioral modifications, and that's just another one of those. It's like unintended consequences of something that now we're hiding the behavior instead of fixing the behavior, and it actually made it worse. And that was just something that popped in my head when we were talking about this risk profile.
For sure. Zena mentioned that saying traveling technicians often are tired after long work days, and they decide to drive back instead of checking into a hotel. That's a great point. I think that so many times that's happening, not just in yours. I don't think that's specific to yours. I think that is, industry agnostic, I'd say, for where some of these things are occurring. Would you guys agree?
Yeah, absolutely.
Yeah. All right, let's get on to number one here. And you guys will have to let us know if you're surprised by this. I doubt you will be, but you'll let us know. All right, Dr. Cherry, sprains and strains, number one injury.
Yes, and so this is really the bulk of injuries, and so it's interesting that one type of injury is for us it's 51% of injuries, so almost 7,500 cases. But I think we know that, kind of whether we're actively thinking about it or it's kind of in our gut, but sprains and strains really have always been the bulk of the cases. So again, think of back, neck, shoulder, and this can be kind of a mix of acute injuries and maybe even some chronic chronic wear and tear that ends up manifesting as an acute sprain or strain. But with this being really the bulk of injuries from our collective experience over all of our clients, it most likely is going to be the biggest bulk of injuries for almost every client out there individually. And so having a program that focuses on sprains and strains is really going to be one of the biggest areas of opportunity for, if you have a really good program there, it's going to, potentially affect half of your injuries, right? And so, I'll leave it at there, Holly, and I know we're going to talk about some insights and best practices shortly too.
Yeah, and this has been a big pain point that's came up, and it's came up a lot. And Dara, I'll come to you first and kind of let you talk us through this subject. And then I think that you may refer up to Dr. Cherry and kind of get his expertise too. But does it feel like that there's an overuse, or what is the association with physical therapy and some of these musculoskeletal types of sprain strains?
Yeah, I may actually start with Dr. Cherry. Dr. Cherry, I want to maybe come back to a statement you made earlier and reinforce it. So this concept of first aid or treatment beyond first aid, can you talk a little bit about the list of included first aid recommendations and whether, anything beyond that list and kind of how we work within that framework, and why?
Certainly, so really we start about, again, assessing the mechanism of injury and then getting a good sense of what the injury is. But we really believe the good medicine is good business for our clients. And so we're never trying to minimize an injury. First off, I think a lot of times when we have a focus on, OSHA recordability, a lot of times that means, trying to reduce or minimize what a true injury is. And so my focus has always been, again, good medicine is good business. So having the best outcome for each injured employee is the best outcome, for each client. And so a lot of times, just because of the way the medical model is, and when injured employees end up going to the emergency room is not necessarily there to provide efficient injury care. They're really trying to rule out emergencies first. And so there's also a concern about follow-up. So the best treatment is having adequate follow-up to make sure the patient is improving. A lot of models for emergency rooms is it's called a shotgun approach. So they basically give everything to the patient to where they're never going to see that patient again. And so the inefficiency there for injured employees is that they're going to get a lot of medical care that may not be appropriate at that initial assessment. And so I think for sprains and strains, this is an easy one. So it's the bulk of injuries. And so an ER doc is just going to prescribe, Motrin or some type of non-steroidal anti-inflammatory medication, and that instantly will be an OSHA recordable. You can give over-the-counter, ibuprofen, and it's, really the same outcome, but it's not recordable because it's not at prescription strength. Also with sprains and strains, a rigid, so there's about 11 there's around 10 listings on that OSHA guidance. But the big ones are a prescription medication that's really not indicated at that time, even if it's an antibiotic as prophylaxis for infection. But what really I think gets a lot of folks here is a rigid splint. So someone sprains their ankle, if they're given if they're given a rigid, anything that's inflexible, it's considered, medical treatment beyond first aid. So there's other ways to provide splinting that's non-rigid and therefore does not invoke, an OSHA recordable. So those are really the bulk components of that, Dara.
So one of the trends I know we've been tracking a lot and seeing a lot of is post-injury muscle manipulation, massage, kind of this,
Yes.
Physical therapy. Maybe just mention, what we're seeing in the industry, where that fits. And so,
Right.
we don't want to get into a discussion about whether that's right or wrong and whether it should be recordable or not, but just where that fits in a treatment plan. And then what is physical therapy and why would it be used to manage a sprain strain?
Certainly. And, so physical therapy is really, physical therapy are exercises or, I'll leave it at exercises that are guided by a licensed provider. And so, again, that immediately will cause it to become medical treatment beyond first aid. Every provider is different. Every medical system may have a slight kind of approach to, treatment along these lines. We are aware of some providers that really have that as a very early option. So, again, if an injured employee goes to one of those clinics where they're offering or prescribing physical therapy on the first visit. And really there's guidelines for physical therapy depending on the severity, how long the condition's been going on for. Again, for most injuries, a conservative management treatment is very effective, or at least until some follow-up days or weeks after the initial injury. Every injury is different, but if every injury is being recommended or prescribed to have physical therapy, that is something you do want to look at, because again, it's going to cause an OSHA recordable in many ways, but is it really an appropriate or medical referral use of that treatment protocol? So,
yeah, thank you for kind of talking us through that. One of the things, not to ever name any names, but there are a lot of providers in the United States that tend to make money prescribing physical therapy. And when you think about kind of this medical model that we've got in the United States, not that we ever want to prevent an employee from getting the treatment that's necessary for the injury they have, but looking at appropriate care, making sure employees are getting what they need. And we definitely see a lot of cost and other downstream effects of an employee that is dealing with a really long, protracted physical therapy prescription. And so it's something to keep, like you said, keep in mind, be thoughtful about. And we've seen, again, not to call out any providers out there, but we've seen some situations where it really doesn't even make sense to be given physical therapy. One classic example that Holly and I bring up a lot is we had an employee that had a bee sting. And then on the case, we saw the person with the bee sting be given about a week of physical therapy, and it didn't, why? Why would you be given that? And it didn't make a whole lot of sense in the scenario. So just something to keep a close eye on.
Yeah. Tracy Jones was asking, does massage make it recordable? Dr. Cherry?
So, so the questions here are very sometimes intricate, but what you can think about is if a licensed medical provider has recommended it in response to an injury, it usually is considered medical treatment beyond first aid.
Yeah. Anything that doesn't fall within the list, the OSHA's first aid list. Is that correct?
Right.
Yeah.
Correct. Yeah, you can Google the list. It's pretty kind of common out there. That way, it's one of those things where it's almost like check every, dot every I and cross every T type of thing. But it's very helpful.
Absolutely. And there's a difference between, recordability and then compensability. And I think somebody made a comment about work comp and work related and workers' compensation, and what workers' compensation will cover as a compensable injury is a different thing to consider than whether it's an OSHA recordable within this framework. And both are important and both need to be looked at when you're managing injuries. But it is two very different things that you're looking at. So something might not be recordable, but workers' comp may decide to cover it, and it may end up being compensable. So, just a couple things to think about when you're thinking about these terms and partnering with people, partnering with medical providers and people that do this. It is important to make sure that they understand both components. And there are a lot of state regulations around workers' compensation versus OSHA recordability, which is a federal program.
Yeah, I kind of think of them as twins, even though I don't have kids, but they're kind of going in the same direction, but they can go in their own direction, right? And so they're both very different legal systems to administrate. And I think each department kind of has its own focus as well. But you can see something that's accepted as a fairly costly workers' comp claim, but may not be OSHA recordable, and vice versa. You might see something that's OSHA recordable, but actually avoided workers' comp claim. So I've seen all kinds of iterations of this.
Absolutely. Well, we are nearing time. Let's talk about insights and best practices, and then we might even give you a few Thanksgiving injuries if we can get to them in time before we wrap here. Dr. Cherry, talk to us about what our key takeaways are here. What can you do about all of these top 5? Where do they need to go?
Mm-hmm. Well, I think kind of what the topic of this webinar is really probably good information for your employee population, right? Advising them, hey, here's the most common thing that is occurring: sprains and strains from falls, from flying or falling objects. But, there's also all of these other things that are happening, and potentially even just knowing internally, I know our clients kind of get an executive summary every 3 months, kind of on what kind of injuries they're seeing. So, you can just take that information and make it kind of part of a lunch and learn, or just a safety stand down debrief. Because again, if I think slips, trips, and falls again are the most common thing out there, but I think people maybe discount it. They're worried about the heat injury, or they're worried about the traumatic brain injury, but it's a simple sprain and strain of an ankle or a wrist, right? That's more than half of the injuries. So again, employee education is key. And then maybe even having an open dialogue with your workforce, because they may have feedback on, oh yeah, everyone falls in that area, or, in that certain location, et cetera. So kind of having open communication and feedback is really helpful. I'm really a systems-based approach person, and I know a lot of people are in the safety realm, but having a formalized injury reporting process is absolutely critical, because that way you have a comprehensive system that's catching everything. In fact, a lot of times now employers are the most progressive, are actually having near miss reporting, right? So you're getting, kind of these leading indicators that, I almost fell, but, again, that's a risk for everyone that potentially will fall. And then you can do this type of analysis with regarding, everything we've been talking about, whether it's fatigue assessment, personal protective equipment utilization, et cetera. And again, even having that feedback from us about chronic medical conditions eventually will be very impactful, I think, as well. And then, I think our other big component that we probably didn't talk about much today, but it's probably one of the most valuable things, is early intervention. So having those injuries evaluated and treated as soon as possible make a huge difference with regard to the outcome, but also about OSHA recordability. I know, Derry, you kind of have that kind of those metrics in the back of your head. I remember it, but I'm a little fuzzy right now. But again, early intervention is absolutely critical. You never want to hold off on reporting an injury, because there's just so many things that can go wrong.
Yeah, we used to say 24 hours. We used to track it by a 24-hour period. We now have gotten more granular with our clients, and we track it down to the hour, and want to get involved within the first hour. But the traditional statistic was that if you delay reporting for 24 hours, it increases the chance of recordability by 60%. And it is a huge curve, exponential curve to the right. So it very quickly goes very high in your likelihood that you would have a recordable injury the more it's delayed, the longer it's delayed. And then one other quick point, I know we're at time, but the other piece of this that is a term thrown around a lot, but psychological safety. The more people feel comfortable reporting near misses, even, the more likely that you're going to build that culture of safety and encourage people to pay attention to preventing injuries.
Absolutely. Tell us what people need to be looking for this Thanksgiving then, as we wrap up. We've got 1 minute left. What type of injuries should they be watching for? As I looked at the list, it kind of correlated. Yeah. You're
sick of this topic?
So, that's kind of number 2 here, right? Food poisoning. So that was kind of my relatively poor joke. But, whenever you're doing something that's part of work, right? Like it's potentially included in on, work relatedness. So, burns and cuts with dealing with the food, food poisoning, right? So if someone brings in something tainted and it hits up a good proportion of the workforce, that can be difficult. Choking, and again, people traveling to get things, for the party or for the certain type of event, so motor vehicle accidents. I actually will advise my friends that are over 50 to get rid of their ladders in their house, like especially like they're celebrating their retirement at whatever age. It's like, okay, this is also the time you get rid of all your ladders over like 3 feet, because falling from a ladder is huge. So I think decorating falls is making the list as well.
Absolutely. And we had several questions that had came in. We're at time here, but William, I see your questions about the metrics and how that would be appreciated to you, and we will make for sure that you get some metrics there for your meetings. And then Jane, your question about determining how long physical therapy should be, we're happy to have that conversation with you. We can definitely do some medical evaluations and get some physicians' written opinion, things like that. Well, thank you all for attending today. We appreciate it. We hope you have a fantastic Thanksgiving. And if you haven't already, make sure that you click that button to get registered for the next event, and we will see you in December. Thank you.
Thank you, everybody.